right. Welcome, everybody, to the latest in public health research. Today, we're really happy to have you here, and we're really excited to have Dr. Barbara Laraia, who's Professor of Public Health Nutrition in the Division of Community Health Sciences, join us today to talk about her recent work with food insecurity during pregnancy. So I will hand it over to Barbara. Thank you for being here.
Great. Hi, everyone. I'm really delighted to be here. Thank you, Lauren, for inviting me. And I really want to thank Lauren Goldstein and Jen Ahern also, who started this series a few years ago as part of our research efforts in the School of Public Health. So it's really great to have this venue. So I want to talk a little bit today about one area of my research, that's food insecurity during pregnancy. And this is a kind of a life course in intergenerational effects is how I kind of end on the talk. But in a bit of background, why I'm concerned about this topic, because we're seeing over the last decade or so a number of risk factors for poor maternal and infant outcomes. One being, for example, pre-pregnancy weight. So more and more women are entering pregnancy with a BMI of 30 or greater. So, and that leads to a number of risks, poor health outcomes for the mom. More likely to have cesarean birth, more likely to have gestational diabetes, and a number of health outcomes for the child. Also, diabetes during pregnancy, so gestational diabetes mellitus is on the rise, and we see pronounced ethnic disparities in these various risk factors and outcomes. Preterm birth has also been creeping up, and this is data from the March of Dimes, but the United States has the highest prevalence of preterm birth of all developed or high-income countries. So we already are starting at a high prevalence, and that continues to rise. And more unfortunately and scary is that pregnancy-related mortality is also increasing. And so a number of these conditions and outcomes are definitely influenced by diet and nutrition during pregnancy and food insecurity. So I want to step back a little bit and talk about what is food insecurity and how we measure it. Really talk about monitoring the prevalence and to strengthen programs and policies. A bit about a conceptual framework that I'm working on with an international group. And then finally investigate the life course and transgenerational effects of food insecurity. So what is food insecurity? I wish this was more interactive so I could see a show of hands, but I'll just give a couple definitions and some thoughts about how we're measuring it. So the actual definition started back in the 70s from the Food and Agriculture Organization of the WHO. But in 1996, they defined food security, so I'll start with that, as it exists when all people at all times have physical and economic access to sufficient, safe, and nutritious food to meet their dietary needs and food preferences for an active and healthy life. So here's the definition. I love this. It's really speaks to the multidimensionality of food security and ends up focusing on this need for active and healthy life. So in the United States, back in 1990, we defined food insecurity as at the household level. And so a household is defined as food insecure if they face limited or uncertain availability of nutritionally adequate and safe foods, or uncertain ability to acquire acceptable foods in socially acceptable ways. So I'm smiling because it's just quite a mouthful. But again, really trying to get at this multidimensionality of food insecurity with a focus on food quantity, quality, and access, and that kind of social acceptability. And then the FAO in 2006 put out their definition of food insecurity is a situation when people lack secure access to sufficient amounts of safe and nutritious foods for normal growth and development and an active and healthy life. So the focus has been on kind of undernourishment and stunting and inactivity. Okay, so as I mentioned, food insecurity has this kind of multidimensional phenomena. So there's a psychological component, the worry about enough food, and so a number of studies have found an association between food insecurity and mental health, specifically stress, anxiety, and depression, but also a number of other emotional distress factors and stigma. So that's it's very compelling in and of itself. And then there's this nutritional component, the compromise of quantity and quality of food. Again, a number of studies have found an association with not only food intake and the nutritious food, but eating behaviors and uh, and diet quality. And then finally, there's this kind of economic or material deprivation component. Food insecurity is not the same as poverty. It's not, we can't just use income or the income to poverty ratio to be a proxy for food insecurity because it's not the same thing in it, but it really captures something unique about the way families handle trade-offs within the household. Okay, so these are the 18 items that the USDA uses. They're designed to go from the least severe, that kind of worrying that food would run out, to the most severe. And as it progresses, the most severe are adults and children in the household skipping meals, skipping whole days of food, losing weight because they didn't have enough food because of financial constraint. We use these items to categorize levels of food insecurity. So at the least severe level is what we call marginal food security. So it's the anxiety about the quantity and quality of food. And then there's low food security. That's the actual reduction of quantity and quality, variety and desirability of food. And then low food security. So answering 6, 7, and 8 items on the scale. And that really focuses on disrupting patterns. I think, I don't know if many of you heard, but last month, the administration announced that we will no longer, the USDA will no longer be collecting the data at the national level to provide the prevalence estimates for food insecurity. And so we've been trying to think of ways that we can measure this across the country. Okay, so speaking of prevalence, I think as a public health practitioner, it's prevalence and monitoring and surveillance is just so important to really understand if our programs and policies are working. So back to these 18 items, we now have a bunch of subscales that have been validated, with reliability against the full 18 items. So in green at the top are 2 items, the worrying that food would run out and that food that they bought didn't last at the household level. These are considered screening items, and they've been validated against the 18 items, and we call these the hunger vital statistics, or the vital signs, I should say. And many healthcare administrations are starting to implement this within emergency departments and at annual visits with individuals, children, and families. So this is something to put on your radar, perhaps. In blue are the 6-item validated scale that many people use as a shorter form, and then the 10 items are focused on adults, and that's a combination of those 2 vital signs, the 6-item, and then the remainder of the adult level. So, different studies use different measures, but they've all been validated against the 18 items. So I'm going to start with talking a little bit about what we have here in California, which is the maternal, child, and adolescent, the maternal infant assessment survey, or MIHA as we call it. So at the state level, once a year, the state interviews pregnant people. It's a random sample from the the birth records. And so what we find in California, what they did is they used that 6-item short scale, and they asked, instead of at the household level, they asked the pregnant people a number of questions. So again, the worrying, the food they bought didn't last, couldn't afford balanced meals, cutting size of the meals, and felt that they ate less during pregnancy, etc. So using these 6 items, we found in at one snapshot between 2010 and 2012 that 12%, 12, almost 13% of pregnant women were low food secure. Another almost 6% were very low. And then you see the 9.4% were like worried about food, so that marginal food security. So the combination of 28% of pregnant people were feeling some level of food insecurity. The marginal food insecurity group I find very interesting because they're so much more similar with regard to social demographics to the food insecure group, and they also have similar associations with health outcomes. So I find this is really important because the worrying about food lasting really can disrupt metabolism and health. And I'll talk a little bit more about that later. So this is completely unacceptable. 28% of pregnant people experiencing some level of food insecurity. So across time, it's showing you the trends of food insecurity at the national level, which is this green line and the orange line. At the state level, the blue lines, and then in MIHA among pregnant people. So you see, just looking at this blue line, oops, sorry, I'm going to talk about that in a moment. The blue line, here's California prevalence at the household level of food insecurity, and it stays higher than the US, and then has dipped lower, starting in about 2013. And for pregnant people in the MIHA study, we see a much higher prevalence of food insecurity. So I really think it's important to separate out this group. Higher prevalence could be for a number of different reasons. Pregnant women and pregnant people have unique nutritional needs. They need nutritionally dense food that might cost more. They're often they lose their job, or they go on leave, or they reduce their hours, so they reduce the income in the household. Some have to go on bed rest and also have not only reduced work hours, but then need additional help in the household. So pregnancy can be very expensive. I want to point out that in 2008, during the Great Recession, we see food insecurity spiking both in California and among pregnant people in the MIHA study. And if you remember at that time, there was a bunch of federal initiatives that really focused on labor, infrastructure, and different community projects. Because of the Great Recession, it was focused on jobs. Since 2012, we see food insecurity declining. And what's interesting here is in 2021, right after COVID or right during COVID, most people have learned or heard that food insecurity was higher during COVID. And actually, overall, during that year, the prevalence of food insecurity really didn't change between 2019 and 2021. And that we really believe was due to the administration, the USDA, really providing a number of resources, food resources in particular. So, for example, those receiving food stamps, instead of kind of a graduated amount that they would receive based on their income, everyone received the full allotment for food stamps. Children in school lunch and school breakfast now received that income, the amount that would be paid to the schools on a electronic benefit cards as cash. There were food boxes and other pandemic-related resources. And so we see that food insecurity actually did not increased during that time. However, for pregnant people, we see it spiking there. So this is kind of an interesting curiosity that I want to investigate more. So there's some evidence that really responding to food insecurity with these federal programs really assisted quite a bit. So looking at the pregnancy risk assessment and monitoring system, so in California, we use the MIHA study, so asking pregnant people how their pregnancy went. Across the country, it's really PRAMS, this pregnancy risk assessment. So the CDC administers this through the states. So at the state level, they take a representative sample of pregnant people from the birth records. And there's a core set of questions and then some additional standardized questions. So 10 states only have asked about food security. And so they only ask it using this one item. During the 12 months before your baby was born, did you ever eat less than you felt you should because there wasn't enough food? And across the time frame that I looked at, 2016 to 2020, 9% of pregnant people responded that they did not receive enough food. What I find very interesting is that that was the prevalence over that time span, kind of pooling all 10 states. And so you see here in this purple dashed line that the prevalence of food, and I'm going to call it food insufficiency because it was just really that one question. The prevalence of food insufficiency remained more or less the same across 2026 to 2016 to 2019, and then decreased quite a bit in 2020. But I'm finding it fascinating that within a state, for example, Maine here, it started really high at 13.5% and then decreased to become one of the lowest prevalence of food insecurity during pregnancy. So there's this really high within state variation, and there's a really high between state variation. So in 2016, the prevalence of food insufficiency ranged from 6.5 to 13.5%. So this again is another indication of how much these data can really help us understand at the state level and at the federal level what programs and policies are working. So we can tease that apart with more data at the state level. The good news is that in 2023, the CDC decided to move food insecurity question to the core question. So all states will be asking food insecurity, but using this two-item hunger vital sign, which is those two questions about worrying. The bad news is that the data are not available and PRAMS is no longer being administered at the moment because of the current administration. So I'm hopeful that in the future, this long-standing surveillance system will come back online and we can monitor food insecurity during pregnancy. Okay, so there's a lot that has been done on food insecurity during pregnancy. We have a ways to go to understand. So I've been working on a conceptual framework with this international group. But first I'll start by talking about a conceptual framework that I published back in 2013. This was really focused on chronic conditions. But the data at that time, and I continue to find these phenomena that food insecurity presumably works through metabolic disturbances. It really is associated with increased adiposity, visceral adiposity in particular, and insulin resistance, which can lead to a number of health outcomes, early onset puberty, diabetes, chronic conditions, and complications. So I started with this conceptual framework, and then I went to the literature. And a number of meta-analyses have been published in the last couple of years. So I want to focus a little bit on this. So I'm trying to understand the landscape of food insecurity during pregnancy and what's been published. So these are studies that are only meta-analyses. And so the meta-analyses have found that pre-pregnancy obesity, so having that BMI greater than 30, is associated with higher odds of actually experiencing food insecurity during pregnancy. Separately, food insecurity is associated during pregnancy with higher odds of stress, mood disorder, anxiety, and depression. Separately, it's associated with either inadequate weight gain or excessive weight gain. So there's that metabolic disturbance, and then directly associated with gestational diabetes mellitus and also decreased odds of breastfeeding. So we're starting to see this clearer picture of the impact of food insecurity on mental health and on metabolic health. These meta-analyses did not find, however, an association with birth weight, preterm birth, small for gestational age, or large for gestational age. And so taking this conceptual framework and thinking about the next steps, I really think that we need to do more work really understanding about diet, eating behavior, and dysregulated eating. There's been some studies published, but to date, not a meta-analysis or pooling of understanding food insecurity during pregnancy. Work needs to be done to try to really understand how food insecurity gets under the skin, and what's the path? How is it operating? Is it through the stress pathway, through the weight gain pathway, and how is this food insecurity influencing these outcomes? There's some data that suggests that food insecurity is associated with birth defects and maternal infant bonding, as well as preeclampsia and hypertension. So a number of things still need to be done. And so working on this conceptual framework, I started with my own thinking, the literature, and then the WHO's conceptual framework on social determinants of health. So applying that to food insecurity during pregnancy, I think pregnancy really needs to be thought of in the more social determinants of health, because we have a number of interesting policies at the state level, the federal level, food policies, health policies, leave, maternal and family leave policies, and wage policies. Again, the United States is the only country among higher upper income countries that does not have a federal family leave or maternity leave policy. And then more and more food insecurity is seen as a social determinant of health that then can affect adverse outcomes. So here's our overall conceptual framework that we've been working on. So taking into account those policy level, community level, availability of healthcare, mental health, and cultural beliefs, specifically during pregnancy, household level concerns, these kind of pregnancy-specific barriers or challenges where there's an increased need for dietary intake, there's unpaid job leave and bed rest, and also a number of financial and emotional support challenges in pregnancy. Food insecurity during pregnancy then would operate through nutrition, behavior, and mental health, and there's presumably interactions among all. Looking at clinical markers is really important. There's, again, some suggestion of an association with anemia, insulin resistance, and blood pressure, and then finally those birth outcomes. And so really understanding the path can really help us focus on what interventions need to be done and how federal policies can help decrease these outcomes. So an analysis that I'm working on is trying to understand if gestational weight gain does mediate the relationship between food food insecurity and birth outcomes. So using the PRAMS data, the CDC pregnancy risk assessment and monitoring. This is a pooled sample of 47,000 women. And we looked at food insufficiency first and its association with gestational weight gain. And like the meta-analyses, we find that there's higher odds of either gaining inadequate weight or excessive weight. So food insecurity does not have a linear relationship with weight gain during pregnancy. It's U-shaped. And it really speaks to kind of this metabolic disruption, trying to monitor food intake and getting the right food during pregnancy when one is food insecure is particularly challenging. We find this is just, descriptive statistics that food insufficiency there was a higher prevalence of preterm birth, small for gestational age, and a lower prevalence of large for gestational age infants in these data. However, in adjusted models, food insufficiency was not associated with preterm birth, small for gestational age, but was associated with lower odds of large for gestational age. So that was curious. When we added weight gain, adequacy of weight gain to the model, which is a mediator, we see that either inadequate weight gain during pregnancy or excessive weight gain during pregnancy is consistently associated with these three birth outcomes. So weight gain is a real challenge, inadequate or excessive during pregnancy. And it's interesting that the coefficient or the point estimate on each of these food insecurity points did not change. So adding weight gain to the model didn't even nudge these estimates for food insufficiency. I then went on to do a full mediation analysis. It was a causal mediation analysis, and there was no evidence of either effect modification between food insufficiency and weight gain or mediation. So any association that food insufficiency has with the outcomes is operating seemingly separately from weight gain. So finally, I'm going to talk a little bit about investigating this life course and transgenerational effects of food insecurity. And I'm going to take a step back and talk about these series of studies that I find fascinating in animals, using an animal model. This is a bonnet macaque paradigm where psychologists over a couple of decades were looking at maternal infant bonding using the bonnet macaque. And they created a stress paradigm using food. So this is called the variable foraging paradigm. So the variable foraging paradigm, there was three conditions. One is that bonnet macaque moms had daily ad lib availability of food in their environment. So the moms, for 16 weeks, a food cart was rolled into their environment and they could eat ad lib. Second condition, the moms had to forage for the food cart. So the food cart was hidden every day in a different location. And the third condition was the variable foraging condition, where for 2 weeks, the cart was there in the open, and followed by 2 weeks of it being hidden, and it went back and forth over 16 weeks. What they found was that the mother bonnet macaque was stressed, visibly stressed, aggressive with other bonnet macaque moms, and spent a lot less time attending to the infant and doing the different grooming behaviors. For the mom, her stress level through hormones and neurotransmitters, it really increased if during that late variable foraging. So when the baby was a little bit older, the moms got really stressed with this variable foraging protocol. The infants were stressed both in the early part of their infancy and the late part of their infancy. So their actual hormones are, and they had a number of other hormones that they looked at, were increased. And they followed these macaques, the baby macaques, until they were age 4, which is, adolescence in this group. And so they found that at age 4, those that had their moms go through the variable foraging paradigm, the infants or the adolescents at that point, they weighed more, they had a higher BMI, and they had a higher abdominal circumference, which is associated with insulin resistance. They also had higher insulin resistance, both insulin and glucose. And so the researchers likened this paradigm to household food insecurity in the United States, and they conclude that our data suggests that early life stress during critical periods of neurodevelopment can result in the peripubertal emergence of obesity and insulin resistance. So to me, the fascinating thing is even as a nutritionist, this is all operating through stress. There was plenty of food in the environment. It was just the stress of finding the food. So everyone had the nourishment that they needed, the calories they needed, but it was through this stress pathway that it disrupted metabolism. There's a series of qualitative studies that I worked on with Cindy Leung. She looked at adults in the household in one study, adolescents in a second study, and children in a third study, and really tried to understand this kind of emotional response to food insecurity. So among adults, they talked about financial stress, lack of choice in food, stigma, sadness, guilt, and shame. For adolescents, they talked about this daily stress of not knowing about where the food was going to come from, a hopelessness, feeling like they had superficial friendships, and they talked about feeling really isolated, a sadness, fear to disappoint, resentment, and frustration. And then for children, it was worrying about having enough food, embarrassment, worrying about their parents. Parents think that they're hiding this from children, and children are just so smart. They're very aware. Their own sadness. So you see sadness across the three research papers, and then a strain on the family dynamic, anger, and frustration. So it's more than just stress and anxiety. These is really suggesting this kind of real emotional distress that food insecurity causes. And I'm going to end with this study that we just did, looking at this kind of intergenerational transmission of food insecurity in the Growth and Health study. This is a cohort of women that were recruited back in 1988 and then followed over 10 years. And now we revived the cohort when they were 40 and then also enrolled their children. So we asked retrospectively about the mom's experience of food insecurity when she was a child. And we have a lot of data that we use to then test that for reliability. We have a lot of income data and education and et cetera. So we found the measure to be reliable, this retrospective measure. And so mom's retrospective memory of her own childhood food insecurity was associated with her current food insecurity status. The children were asked separately a different food insecurity scale that really spoke to that kind of socio-emotional response to food insecurity. And so the mom's current food insecurity status was associated with her child's reporting of food insecurity. And then we looked at whether the mom's childhood food insecurity was associated with her child's food insecurity, and no, it was not. But in causal mediation analysis, we did see that there was some evidence of her current food insecurity status mediating this relationship between her past food insecurity and her children's. So Not only is food insecurity during pregnancy really important to combat because of all of these metabolic health outcomes that can happen, but also breaking patterns of socio and behavioral responses to food insecurity. So, concluding, I think it's really important that we have some information about the prevalence of food insecurity during pregnancy so we can monitor policy interventions and optimize programs. We have some great programs in the United States, such as the Women, Infants, and Children Study, WIC, and of course, SNAP and many others. Food insecurity really needs to be measured at that kind of individual level for pregnancy. Much more work is needed to identify the pathway through which food insecurity gets under the skin and influences health outcomes. And little is known about food insecurity during pregnancy and how it influences growth and development over time. Most of the studies in children are really asking about their experience during childhood, not really understanding this kind of developmental origins of disease kind of protocol or paradigm of food insecurity during pregnancy and its long-lasting effects. So I'm going to stop there, and that's all I have for you today. But thank you for listening. I really appreciate it. And if there's any questions, please let me know.
Great. Thank you so much, Barbara. That was really fantastic and really interesting findings. So thank you so much for sharing that with us.
Mhm.
Yeah, please, if people have questions, you can feel free to post them in the chat, or you can unmute and ask a question. Here I see one from Steph. I'm interested in the association of the degree of food insecurity with obesity. I would have expected it to initially rise with increasing food insecurity and then fall with even greater food insecurity from global data. But if I understood you, it never falls in your population. I'm also surprised at the lack of association between preterm birth and low birth weight, not because of the lack of sufficient food being injected, but because of the association of food insecurity with stress, unless you were controlling for stress in your
Right.
model.
No, we weren't.
Okay.
Yeah, great. This is, yeah, fascinating stuff. So in non-pregnant populations among women, we find a pretty consistent association in the United States of food insecurity at all levels, even the very low food secure and higher weight among women. We find either no association or even underweight among men. So men seem to maybe cope with food insecurity in different ways. And then it's there's really not a consistent association for children. So, but in pregnancy, it is interesting that the weight gain is either low or high, inadequate or excessive. And a few studies that then follow women over time find higher postpartum weight and not lower postpartum weight. Globally, that's a great question because many studies, there's not a lot of studies globally. So this international group that I'm working with, we tried to, look across the globe, and it's mostly higher income countries that are asking about food insecurity during pregnancy. And there's not a data set that we could find or even published data on food insecurity during pregnancy in low income countries. So your hypothesis could absolutely be correct that we would see it weight fall over time. And yeah, I'm really fascinated by this null finding that's pretty consistent with preterm birth and low birth weight. And love to have anyone chime in. But one way I'm thinking about it is uh, that the mom, as a host, probably does do a lot to protect the nutrients and the overall milieu of the fetus. And so there could be some real protective effects just biologically. The other thought that I've had is, preterm birth is kind of an umbrella term for multiple etiologies. And so oftentimes preterm birth is just this kind of thinking, we're thinking of it as just one homogeneous kind of outcome. And so if we could parse out the various types of preterm birth, maybe there is a type of preterm birth that's associated more with food insecurity and diet. Um, and then I'm not sure about small for gestational age. I was really surprised. Yeah.
But the one thing on the birth
Mm.
weight, not so
Mm.
much the preterm birth, is
Yeah.
to control for gestational diabetes because that's
Yeah. Sure.
that's going to balloon it for
Right.
the association with obesity,
Yeah,
and
absolutely.
it will artificially mask it unless you're
Right.
controlling for that.
Yeah, we tried to remove them as best as we could, but the data are challenging in birth records. That's great. Thank you, though, for that. Any other questions that you might have? Curious about the role of mothers pre-pregnancy, BMI, and gestational weight gain. Did you look at the links? So there's pretty consistent data on just on that, separate from food insecurity, that pre-pregnancy weight interacts with pregnancy weight gain and has higher odds of a number of poor birth outcomes. But I only controlled for pre-pregnancy weight. We didn't really um, look at like a three-way interaction if that's what you're suggesting, but that would be interesting. So we did not look at weight, pre-pregnancy weight, weight gain, and food insecurity. If that answers your question. Okay, data from Mexico, but did they ask about food insecurity?
Well, we have very detailed diet data,
That's awesome.
which is different from subjective food insecurity. So we didn't really focus on subjective food insecurity. Do you feel food insecure
Yeah,
as opposed to what did you actually buy and eat? So
yeah.
we've done a lot of work on diet, but not a lot on subjective
Mm,
food insecurity. And I think it
mm.
would be really interesting to combine those two. And in fact,
Yeah,
next time I'm down there, I will discuss that with the head of nutrition because it would be easy enough to add a few questions to.
absolutely. And they, nationally, Mexico already implements the full food security module in their equivalent of NHANES. So there are a lot of data coming out of Mexico looking at food insecurity. But yeah, um, and a lot of times we're just c- creating kind of a dichotomous food insecurity, so grouping the very low with the low. And I think severity of food insecurity also is going to play a big role in this. But so often in the United States, there's just such a small, you know, the samples are usually convenient samples, smaller, and then there's a small prevalence of very low food security. So when we can really have a larger sample and parse out those levels, then I think we might see something different emerge. Great. Yeah, love to talk to you about the Mexico data anytime.
Great. Any other questions? All right. Well, I'm sure if you think of other questions later, you're welcome to reach out to Barbara. Thanks again, Barbara, so much for such a great presentation and
Thank
sharing your
you,
work. We
Emily.
really appreciate it.
Yeah, I
Hope
really
everyone
appreciate it.
has a good day. Yeah. Thank
Thank
you.
you. Wonderful.
Thanks. Take care.
Appreciate it. Bye-bye.
Bye.